Good afternoon, everybody. This is the 4 o'clock session titled Ultrasound in the Management of Thyroid Cancer. Welcome to this session. I have the honor of introducing our speaker today. His name is Dr. Noureldine. He is an endocrine surgeon at the Cleveland Clinic Foundation in Cleveland, Ohio. He earned his medical degree from Aleppo University, Faculty of Medicine in Aleppo, Syria. His research focuses on examining endocrine tumor genetics and prognostic molecular markers. He evaluates novel ablative and minimally invasive treatment options of thyroid and parathyroid disease processes. So with that, I will turn it over to Dr. Noureldine.
Thank you so much for the kind introduction. It is a pleasure to be here today. This is my first conference with ThyCa. Hopefully the first of many, but I've always admired the hard work and dedication of the people and the patients within this organization. And it's nice to see how they are impacting patients positively and helping them manage their disease process by informing them and providing them with objective scientific information. Today, my talk will be about the importance of ultrasound in the management of thyroid cancer. As you all know, ultrasound has become an integral to a part of preoperative planning, as well as long-term post-treatment follow-up for patients with thyroid cancer. For me, it's a reliable sidekick. It helps me be a better clinician. It complements my passion for anatomy and allows me a view of the relevant vascular, muscular, endocrine, lymphatic, and aerodigestive structures in real time with minimal effort. And my goal today is to provide you with the data on why it's important. I have no conflicts of interest to disclose. The outline of my talk is simple. It will be discussing the role of ultrasound in the diagnosis of cancer, and then I will be discussing its role in surveillance after surgery and monitoring of the disease progression. I'll be using 5 case presentations to summarize my talk. These are real cases that I have come across over the years. And by doing so, hopefully, I would keep you engaged and make my talk as relatable to you as possible. So let's start with case number 1. A 24-year-old woman with familial adenomatous polyposis, a disease or a syndrome that we know to be associated with an increased risk of differentiated thyroid cancer, who has a strong family history as well of thyroid cancer in her mother and recently in her sister, presents to clinic for evaluation. Her primary care provider did not feel any thyroid abnormalities, and her thyroid function test was normal. But she wanted to be more confident and presented for evaluation. And on exam, as you can see here, she has a very slender neck that allows for a reliable neck exam, which shows no thyroid enlargement or any palpable thyroid nodules. And she has no palpable enlarged lymph nodes. So we do an ultrasound of the neck. And this is what we found. She has a thyroid nodule, as you can see here, within the left lobe of the thyroid gland. It is highly suspicious for malignancy because of its irregular shape, its darker color compared to the consistency or the texture of the thyroid gland, and it has a couple of microcalcifications, as you can see here. Plus, it's in a location where the recurrent laryngeal nerve would be, and it would be in this region right here, the nerve that goes to the voice box and helps with phonation. So if this nodule, which was found to be cancer, was missed, it theoretically would have invaded into the nerve and caused hoarseness of the voice. It was not picked up on physical exam because, as you can see, it's deep in the neck and deep on the deeper part of the thyroid lobe, and it's not on the anterior surface right here, where it would have been easier to pick up with physical exam. So while palpation is the kind of reliable method for examining the thyroid gland, it can be insensitive or inaccurate depending on the skill of the examiner. Nodules that are less than 1 centimeter in size are not usually palpated or palpable unless they are located in the anterior portion of the thyroid lobe. Larger lesions are easier to palpate, except those that lie deep in the thyroid gland, as I showed in this case. Regardless, about half of all nodules detected by ultrasound escape the detection on clinical examination. And of those, about a third are larger than 2 centimeters in size. This figure is from a very old study, but it shows the prevalence of thyroid nodules detected on autopsy by ultrasound compared to palpation. As you can see here that, on ultrasound, we can consistently detect more thyroid nodules than by just physical exam alone. So therefore, ultrasound is considered to be the primary imaging tool for the thyroid gland, as it is cost-effective, it provides rapid information, it's well tolerated by our patients, and it helps patients avoid unnecessary radiation exposure, such as CT scans. It reveals nodules as small as 2 millimeters in size. And just to give you some perspective, the tip of a crayon is 2 millimeters. An eraser on a pencil is about 5 millimeters in diameter. So it can pick up really tiny nodules, and it can also reliably evaluate lymph nodes and give us an idea of how they appear as well. So the American Thyroid Association provides guidance on how to manage patients with thyroid disease. And when we read recommendation number 6, it says that thyroid ultrasound, in addition to surveying the lymph nodes of the neck, should be performed in all patients with known or suspected thyroid nodules. And this is a very strong recommendation because we have very high quality evidence at this point to support it. Usually, the components of the ultrasound system are threefold. There's a transducer, which is the probe that we use. It delivers and receives sound energy directly to and from the tissue. The bulk of the system is the console, which contains very sophisticated software, algorithms, and Doppler imaging technology to provide us with images on a display monitor that we can kind of view and select where the areas of interest are. And then when we do the ultrasound, as we all know, the thyroid gland is located in the mid aspect of the neck, right anterior to the windpipe, and just below the Adam's apple, if you have one like I do. And the ultrasound probe is applied to that area. Now, I know this might sound a bit dark, but just think of the sound waves that are generated from the ultrasound probe as a knife slicing through the neck, going layer by layer along the red line that I have drawn here. And this is what you end up with. The top image is an illustration of what we find, which is a cross-sectional image of the neck. And then this is the ultrasound image that's married to it. So if we start from the superficial part, this is the skin of the neck. And then these are the muscles right here. And then right in the middle, where I'm outlining right here, is the thyroid gland. Behind it is the trachea or the windpipe. And behind the windpipe is the esophagus, where the food goes down. And on either side of the thyroid gland, there are the vessels of the neck, the carotid artery in red and the internal jugular vein in blue, as you can see on both sides. And then when we look at the ultrasound, now you can kind of appreciate the structures that we see in clinic. The muscles right here. This is the thyroid gland that I'm outlining here, and that sits around the trachea. And then these are the vessels on both sides. So, this is another image in a patient that does not have any thyroid nodules. You can see here the thyroid gland is free of any growths. But on the right-hand side, this is an image where we're focusing only on the right lobe, on the right side of the patient. This is the trachea, and then this is the right lobe, right underneath the muscle and the skin, and then this is the carotid artery. And as you can see within this right lobe, there is a thyroid nodule. So this is a normal lobe, and then this is an abnormal lobe. And then similar to when evaluating lymph nodes, if we are to evaluate this lymph node on an ultrasound, it would look something like this, where it's, elongated, very smooth, and has a bright shadow within the middle of it, which we call a hilum. And this is a very reassuring picture of a normal appearing lymph node, compared to something right here where I'm kind of illustrating a metastatic foci of papillary thyroid cancer. It would look something like this, where now the lymph node is more round. It's not as elongated as it was before, and has some abnormal growths within it. So this is, concerning for metastatic disease on ultrasound, which was confirmed by biopsy. So let's move on to case number 2. This is a 45-year-old, otherwise healthy euthyroid woman with no history of radiation to the neck has no family history of thyroid cancer. And she presents due to noticing a new lump in her neck that moves with swallowing. So what do? We do an ultrasound, and this is what we find. And again, just to kind of illustrate the picture. So this is the trachea right here. This is the isthmus, or the bridge that's right anterior to the trachea. And then this is the left lobe of the thyroid right here. These are the muscle, and then this is the carotid artery. And as you can see here, within the left lobe of this thyroid lobe, there is a nodule right here. And if I were to describe it, I would say it really has some irregular borders right here. It's darker in color than the consistency of the normal thyroid. And it has these bright specks within it, which we call microcalcifications. So the clinical importance of thyroid nodules mainly rests with the need to exclude ones that can harbor malignancy, which is up to 15% of nodules that we identify on ultrasound. And so the American Thyroid Association has provided us with guidance on what to do with nodules that we identify on ultrasound. And usually FNA is the procedure of choice, which is a biopsy through a small needle where we aspirate some of the cells within the nodule. It would give us a gold standard evaluation almost for thyroid nodules. But they say when it's clinically indicated. And what that means is there is an algorithm that they have created based on the likelihood that that nodule, based on the ultrasound characteristics, were to harbor malignancy. They provided us with this algorithm basically on when to biopsy these nodules based on the ultrasound pattern. So if it's highly suspicious ultrasound pattern or intermediate suspicion, then if it's over a centimeter or more, we biopsy it. If there's low suspicion, once it gets to 1.5 centimeters in size, we biopsy it. If it has a very low suspicious pattern, then over 2 centimeters. And then for anything that's purely cystic or anything then less than 1 centimeter in size, they ask us not to biopsy. So just going into the details of that algorithm. So when they say that nodules with high suspicion, those are the ones that are likely to be malignant, and you can see up to 90%. And those are the ones that have microcalcifications in them, have irregular margins, are taller than wide. There's evidence that they're invading into the muscle around the thyroid. If there's a break within the capsule of that nodule, or if we see lymph nodes as well that are concerning. Compared to the intermediate suspicion ones, those are the ones that have up to 20% risk of malignancy. And those are the ones that we call hypoechoic, meaning the character is darker than the color or consistency of the thyroid itself. Low suspicion ones are hyperechoic or isoechoic, meaning that they're brighter than the thyroid or the same consistency of the thyroid gland, or that have a fluid component to them, as you can see here, where they're dark in color. And those have a risk of malignancy of up to 10%. The very low ones, less than 3% risk of malignancy, those are the ones that we call spongiform, as you can see here. And then lastly, the ones that are considered to be benign with a very low risk of malignancy, the cystic lesion ones. So for the nodules that are least suspicious to the nodules that are most suspicious, they provided us with guidance on when to biopsy them based on the risk of malignancy of these nodules. So the ones that look cystic, no biopsy, versus the ones that are highly suspicious, we should get a biopsy. The American College of Radiology also created a scoring algorithm to help unify the terminology and reports of thyroid ultrasounds. A lot of these imaging studies are done by radiologists, not by the surgeon or the endocrinologist or the physician managing these patients. So rather than just getting a report to try to decipher what type of nodule it is, they unified the terminology and they developed this algorithm where at the end of the day, you get a score for every thyroid nodule. And that's based on the composition. So if it's cystic versus mixed, if it's bright or if it's darker than the thyroid, what shape it has, if it has any irregular margins, or if it has some microcalcifications as I showed, and you just add up these points and then you end up with a TIRADS 1 through 5. And each of those categories have recommendations on when to biopsy them, depending on size and whatnot. And if you compare this algorithm to the ATA one, they're fairly similar. So if we go back to our patient, looking at the ATA system, as I mentioned, so it has some irregular borders. It's hypoechoic, meaning it's darker than the consistency of the thyroid lobe, has some irregular margins, it's solid, and it has some microcalcifications. And then, so when we look at the ATA risk of malignancy, it's in this category. And then we should consider biopsy. If we go by the TIRAD system, the one that was developed by the American College of Radiology, we get 2 points because it's solid, 2 points because it's hypoechoic, 2 points because it's irregular, and 2 points because of the calcifications. So that's 8 in total. Will go under this category of highly suspicious, and a biopsy is recommended. And that's what we did in this patient. So for biopsying, what's nice is that, if we have an ultrasound machine in the office, it allows for doing the ultrasound and evaluating the thyroid, and it also allows for doing the FNA right then and there. It's the same setup. So here, the patient would be lying down, we'll be doing the ultrasound, and this is the cart for doing the biopsy. It is not a sterile procedure, it is a clean procedure. So that's why we use alcohol to clean the skin. And then we usually use 2 syringes with needles that are small as the needles that are used to draw blood or put in an IV if you have ever had that done. And then we have the slides right here. Once we get the tissue, we immediately put them on the slides and put them in the preserving solution to have it analyzed. And then we can also have some tissue for molecular testing as well. Most FNAs are well tolerated by patients. So therefore, we don't routinely use local anesthetic because it provides very minimal discomfort when done properly. However, if there are patients who prefer that we give them local anesthetic, that can be done as well. But the nice thing about the ultrasound is it gives you a roadmap of where the needle is going to make sure that you're biopsying the lesion in question. So as you can see here on this picture, the needle is right here, this bright line, and then it's capturing this nodule within the thyroid lobe. And it's very important to see that this needle is in with the nodules to make sure that we're getting a good sample, rather it being in normal thyroid tissue, right? And then that way we can get a false negative result if we're biopsying this part rather than this part right here. And there are studies that have shown that the use of ultrasound has decreased the number of unnecessary procedures or unnecessary repeat biopsies because we can confidently see where the needle is going and what part of the nodule it's biopsying. Just for practice, let's say the patient that I showed you had this ultrasound findings rather than the ones that I showed you. So again, this is the skin up here, the muscles over the thyroid right here. This is the trachea, and then this is the thyroid lobe right here. And these are the vessels of the neck. So this time we have this structure right here in the right lobe. It's anechoic, meaning it's very dark and it doesn't have any ultrasound echogenicity to it. And when we compare it to the ATA guidelines, the guidance that they provide us, it looks something like this, which is a cyst, and they recommend no biopsy. And similar, if we look through the American College of Radiology ThyRad system, it's cystic, so it gets 0 points. It's anechoic, 0 points, all across 0 points, so no biopsy. So again, ultrasound is really helpful in these situations to determine which nodules need biopsy. Let's move on to case number 3. So we have a 50-year-old man with normal thyroid function, with no history of radiation to the neck or family history of thyroid cancer, and was found to have a thyroid nodule on CT scan of the chest. He was referred to a radiologist who performed an ultrasound showing a suspicious nodule, 1.5 centimeters in size, in the left thyroid lobe, and the radiologist biopsied that lesion, and it confirmed to be papillary thyroid cancer. The patient comes to clinic with the picture that the radiologist provided, and this is what the patient has. And again, this is the skin up here. Here you can see the 2 muscles within the neck. This is the trachea right here, and then this is the left lobe of the thyroid right here, next to the carotid artery. You can see here, there's this nodule within the thyroid. I can say that it doesn't really have any clear borders. It's darker, hypoechoic than the thyroid, and then there are these bright spots which resemble microcalcifications. So the patient is interested in discussing observation versus thyroid lobectomy, which are both reasonable options given recent studies showing that. And his main reasoning is to avoid the need for thyroid hormone replacement. However, we have to go back to the basics first, right? The American Thyroid Association mentioned that a thyroid ultrasound with survey of the cervical lymph nodes, the lymph nodes within the neck, should be performed in all patients with known or suspected nodules, let alone cancer, right? And that was a strong recommendation. So the workup of this patient is incomplete at this point, and he would require a survey of the lymph nodes. We know from studies that the larger the tumor or the nodule within the thyroid is, the higher likely that you're going to have metastatic disease. And that's true for papillary thyroid cancer and follicular thyroid cancer. The larger those cancers are, the higher likely that you have lymph node metastases at the time of diagnosis. In terms of numbers, we know that patients with papillary thyroid cancer have about up to an 81% risk of metastatic disease. For follicular thyroid cancer, that's about 25%, and similar for Hürthle cell carcinoma as well. We know that thyroid tumor cells spread in a sequential fashion. They start in the central compartment right here. This is where the thyroid gland is, and it sits between the big vessels or the major vessels within the neck, and we call this the central compartment. And usually that's where the initial drainage of cancer cells go to, the central compartment. And then the secondary drainage, it's to the outer parts of the neck on either side, the left side or the right side, as well as the upper chest right here. So ultrasound is considered to be the first line imaging modality to evaluate the lymph nodes in any patient with suspected malignancy. And the ATA recommends that we evaluate all the compartments of the neck, and they give us numbers for each compartment. And the main reason for that is, you know, if I were to communicate with one of my colleagues that I have a patient with a level 3 lymph node, he or she would know that they're located in this region. And the levels of the neck are from 1, 2, 3, 4, 5, 6, is the central compartment, and 7 is the upper chest. And we've seen that ultrasound, facilitates identifying and altering the surgical plan in about 40% of cases. And similar to the one that I'm discussing right now, which I'll show you in a bit, we're going from either just observing that thyroid cancer, doing a lobectomy, versus if we find the lymph node, it's going to be more extensive operation. And again, here are the lymph nodes within the central compartment and the upper part of the chest. This is the level 6 and level 7 lymph node basins. And the further we travel away from the thyroid gland, the less likely that we have metastatic disease. As you can see here, the ones in black or brown and red, they're more likely to be involved with thyroid cancer. And the more that we travel further away, the less likely to be involved. However, this is why ultrasound is important, is that even if we don't see anything in the central compartment, there are cases and documented studies that document that there can be skip metastases to those areas that are less likely to be involved. That can happen up to 37% of the time. We also know that children, people that are less than 20 years of age, have a higher risk of lymph node metastasis at the time of diagnosis. Those that have evidence that the nodule is growing outside the thyroid at the time of diagnosis, and those that have multiple foci of cancer within the lobe. So going back to our case, an ultrasound of the neck was performed, and it showed this very suspicious looking lymph node in the level 3 compartment of the neck, so the outer side of the neck on the left side. As you can see, it doesn't have really nice borders, and it looks very concerning compared to a normal appearing lymph node, which is very oval in shape, has a nice contour to it, and the bright hilum within it. And this was biopsied and was determined to be metastatic thyroid cancer. And therefore, the patient underwent the oncologic procedure, which is removal of the thyroid gland as well as the lymph nodes. And as you can see here, I know it's a very dark image, but that's the lymph node that we saw on the ultrasound. And if that patient had undergone a lobectomy or just observation of that cancer, that would have been the wrong recommendation to provide him. So a comprehensive evaluation should always be performed to include the lymph nodes of the neck. Let's shift gears right now and go to surveillance after surgery. So we have a 65-year-old woman. She underwent a total thyroidectomy and a central compartment neck dissection for papillary thyroid cancer. Her postoperative pathology showed a 3-centimeter papillary thyroid cancer with tall cell variant, so an aggressive form of papillary thyroid cancer. She was found to have extrathyroidal extension, meaning that the cancer was starting to spread outside the thyroid, and 5 out of the 6 lymph nodes that were removed had metastatic disease. Because of those high-risk features, she underwent radioactive iodine, and at 6 months follow-up, her thyroglobulin level was low, 1.5, and she had no thyroglobulin antibodies, which makes the interpretation of the thyroglobulin reliable, especially when the thyroglobulin antibodies are not detected. And this is the ultrasound at 6 months. So this is a little bit different here, right? Because she had a thyroidectomy, so her thyroid has been removed at this point. Again, this is the skin, this is the muscle, the carotids on either side, and this is the trachea. And here you notice there isn't really any tissue between the carotids on either side because she's had a complete thyroid removal. As we go to the left side of the neck, again, this is the trachea, the carotid, the internal jugular vein. Here we start scanning the lateral compartments of the neck, going up and down along those vessels to identify any lymph nodes. We do find one, but again, as you can see here, it's elongated, has a nice contour, and has that bright shape, bright color within it called the hilum. So that was a benign looking lymph nodes. And a lot of us have benign appearing lymph nodes. If I were to do an ultrasound on myself, I would find a couple. So that's reassuring. On 1 year follow-up, we noticed that her thyroglobulin level increased a little bit, but by 2 years, we now see that her thyroglobulin level has almost tripled in number. So it's 6.5 right now, and still has no antibodies, which is making the interpretation of this number reliable. So we do the ultrasound. Again, there's nothing in the central compartment of the neck. And then as we're screening along the left side of the lateral compartment, we found this structure. So it's a round lesion. It's very suspicious. And this is what a suspicious appearing lymph node or a lymph node that harbors cancer looks like. We obtain a biopsy of this lesion that's located in level 3, and it was positive for malignant cells. And it was consistent with papillary thyroid cancer. So the patient undergoes a lateral neck dissection, and we find 2 out of 13 lymph nodes positive for disease. And again, we restart the clock and start following her. And at 6-month follow-up, her thyroglobulin level is back to normal, and we continue surveilling her with ultrasound. So let's discuss this case. Whether or not lymph nodes are removed during the initial operation, recurrence most often occurs in the lymph nodes of the neck. So the goal of overall long-term management is to establish accurate surveillance for possible recurrence in patients thought to be free of disease. For low-risk patients, the goal is to use less aggressive management strategies that are more cost-effective and safe. And for high-risk patients, early detection of recurrent disease offers best opportunity for elective treatment. This is a nice figure taken from Dr. Hayes' group from the Mayo Clinic, and basically highlights the ongoing elevated risk of recurrence in those considered to be cured at the time of their initial operation. And as you can see here, they followed patients up to 30 years, and the cumulative risk of recurrence increases after each year. And that's true for children and as adults. This is for local disease, meaning disease within the central compartment of the neck, regional disease, the lymph nodes on the outside of the neck, and then distant metastases as well, where they go to the lungs or bones or areas outside the neck. Therefore, ongoing surveillance is important. And over the past couple of years, we have moved away from whole body scans using radioactive iodine to scan patients and diagnose them with recurrent disease, to using stimulated thyroglobulin levels and high resolution ultrasound. And the reason is because we found that whole body scans had a very low sensitivity in detecting local regional metastases. It did not really alter the management and subsequent care of our patients, and it only really detected thyroid remnant rather than recurrent or persistent disease. That's why we moved to high resolution ultrasound. And as you can see here, it has a very high predictive value, high sensitivity in capturing persistent or recurrent disease, and using thyroglobulin levels as well. I get a question about what is thyroglobulin level a lot. And basically, in layman terms, thyroglobulin is a protein that is made by thyroid cells, and it's used to produce thyroid hormone. So after removal of the entire thyroid gland, the thyroglobulin level could be used as a cancer marker, because there shouldn't be any more thyroid cells in the body. Its number should be as low as possible. Sometimes, the term is undetectable. That's when it's really low, and that's what you want it to be. So for a patient that has their thyroid still not removed or in place, the thyroglobulin level is going to be extremely elevated, right? Because you have all these thyroid cells producing the hormone. If you have a thyroid lobectomy, you're still going to have one lobe remaining that's producing thyroglobulin hormone. But for patients who have their thyroid gland removed, then it should be undetectable. And that's when we use it as a marker for cancer recurrence, because if something pops up in one of the lymph nodes and it's cancer cells that are now growing, you'll notice that the thyroglobulin level starts to rise. And we use thyroglobulin levels in conjunction with high resolution ultrasound to detect suspicious disease within the neck. And a lot of times we've seen that ultrasound can pick up to 60% of nodal metastases that are unexpected, and they can alter the management of the patient in 40% of the time. The ultrasound helps us identify these lesions, and then we can offer a fine needle aspiration biopsy to confirm the diagnosis of metastatic disease. And nowadays we use the thyroglobulin level washout within the biopsy to confirm the diagnosis, because we saw it's more reliable than just looking at the lymph node under the microscope to see if it has any cancer cells. And the ATA, or the American Thyroid Association, recommends that in all patients who have the diagnosis of cancer, even those that have undergone surgery, that the central and lateral compartments be evaluated, and especially for the ones who, after thyroidectomy for thyroid cancer, that they start getting their evaluation at 6 months and then 12 months, and then periodically, depending on their risk. And then whatever we find suspicious ones, we biopsy. And then this image is taken from the American Thyroid Association guidelines, which goes over, who's low risk to who's high risk. So for someone has a microscopic foci of papillary thyroid cancer, it's considered to be lower risk, versus someone who has a follicular thyroid cancer with vascular invasion, which is high risk. And that changes the algorithm of how often or how frequent we see these patients and surveil them for recurrence. But as you can see here, these are the algorithms of follow-up published in the American Thyroid Association guidelines. At every step, there's ultrasound evaluation married with thyroglobulin assay to evaluate these patients. And that's true for low-risk patients, intermediate risk patients, and even high-risk patients. Ultrasound is an important part of their evaluation. And whenever we use ultrasound for patients who've undergone thyroidectomy, this is what we're looking for. These are the suspicious criteria, or the suspicious findings that we don't want to see on the ultrasound. A lymph node that's round, that doesn't have that bright hilum within it, that has some calcification, some necrosis, it's highly vascular, has some reticulation. And so again, a couple of pictures. This is what a normal appearing lymph node will look like. And you can see this bright shape right in the middle of it. That's very reassuring and suggestive of benign appearing lymph node. Sometimes they can be big in size or large in size. As you can see here, it's about 1.5 centimeters in size, but it has the reassuring findings and the bright hilum. Compared to this one, where it's now more round in shape, has some concerning characteristics within it. These are the reticulations I talked about. Again, another one that's highly suspicious. And you can see this one that's highly vascular as well, where we can put Doppler to assess the lymph node. So this is the last couple of cases that I have. And it's basically highlighting the utility of ultrasound in screening for progression of disease or recurrence of disease. The first is a 50-year-old woman with a 9-millimeter papillary thyroid cancer who's undergoing active surveillance. And the second case is a 30-year-old woman who underwent a lobectomy for a 1.5 centimeter papillary thyroid cancer, is also undergoing surveillance. Now, both of those cases are low risk, but as I showed you, that we need ongoing surveillance, not as frequent as ones that are highly concerning or have high risk features, but they do need ongoing surveillance. What's unique in these two situations is the first patient has their thyroid gland still in place, and the second patient has part of their thyroid gland in place. So a thyroglobulin level is unreliable in both of those situations because it's going to be elevated. So if we have a number of 200 or a number of 250, or if it changes from 200 to 300, it's not really going to make a difference in our management because we cannot rely on that thyroglobulin level. But here where ultrasound comes in and shines, where we evaluate both the central compartment and lateral compartment, or evaluate the thyroid itself in this patient to measure any differences in size. As this nodule started to grow, is it starting to spread outside the thyroid? But that's in these two situations, kind of highlight the importance of ultrasound. For the second two, we have a 60-year-old male that underwent a thyroidectomy and a central neck dissection for poorly differentiated thyroid cancer. And we know that some cancers, especially the poorly differentiated ones, don't express thyroglobulin. So we can't rely on that test to tell us if there is any suspicions for recurrence. It doesn't really increase because those cancers don't produce that protein. And then some patients similar to this one, they have elevated thyroglobulin antibodies. Whenever those antibodies are elevated, the thyroglobulin level itself cannot be reliable in giving us an idea if there is any recurrence or not. And that, again, where ultrasound comes in and is important to evaluate all the lymph nodes and even the central compartment where the thyroid gland was, to evaluate for any recurrence of disease. And this kind of basically just highlights what I said, that still in those patients, you would evaluate with ultrasound, and then anything concerning that you find, you would do a fine needle aspiration. And then in those patients, this is the outline or algorithm from the American Thyroid Association. And those that undergo less than thyroidectomy, again, ultrasound is highlighted in the management of those patients. So that's all I have for you. Hopefully you are now all experts with ultrasound and love it as much as I do. Thank you for the opportunity to present today, and I'm happy to take any questions at this time.
There are quite a few of them in the Q&A section.
Okay, so I'll start with the first one. Both low-dose radioactive iodine scans and PET-CT scans have been coming clean, whereas the malignant lymph nodes sub-centimeter in size are being confirmed on neck ultrasound FNA over the last 2 years. Are there any other imaging techniques to detect malignancy in case of distant metastases in the future, especially since the ultrasound can only be done in the neck? So that's a good question. It looks like you have undergone the imaging studies that would identify disease outside the neck, the radioactive iodine scan, and as well as the PET-CT scan. You're right that ultrasound is only useful for the neck, but so coming clean, whereas lymph nodes are being confirmed on ultrasound. So it depends on what the size of the malignant lymph nodes that you have as well. You know, we know that even after treatment, there might be microscopic disease that's left. And the American Thyroid Association doesn't really recommend going after and biopsying them if they're less than 8 millimeters in size in the central compartment or 1 centimeter in size in the lateral compartment, rather than just watching them, because the risk of balance of going back in and taking out those lymph nodes is found to be prohibitive, meaning that if we go in to chase that microscopic disease at this time, can cause more harm to damaging nerve structures or any of your tissues, especially the nerves and the parathyroids, rather than providing you with any benefit. So as long as your radioactive iodine scan is negative, I would just follow with the ultrasound or based on the information of what you gave me. Ultrasound showed lymph node with visible fatty hyaline. Biopsy was negative benign. Follow-up ultrasound, so enlargement of this lymph node. What is appropriate follow-up? Found 2 years after total thyroidectomy. So again, as I showed you, it's very reliable, and you can differentiate between what a normal appearing lymph node would look like versus a suspicious one. One question I would have for you was, when it was biopsied, did they check a thyroglobulin level? Because as I mentioned, when we've seen that when the pathologists look at the lymph node under the microscope, they can miss up to 20% of cancers. But when they check the thyroglobulin level within that lymph node, then they can tell us with certainty, almost 100%, that if it has any cancer cells. And again, you know, taking all of this in the context of what's your thyroglobulin level, is there any concern for biochemical recurrence, meaning is the thyroglobulin level elevated or not. Because as I said, we all have benign appearing lymph nodes. I hope that helps. Is my 7-minute thyroid bed and lateral neck ultrasound likely to miss structural disease? The latest equipment is used at an imaging center, interpreted by radiologist 3D. So that's a good question. We usually, at my institution where I train, is we perform our own ultrasounds, and we follow our patients, 2 to 3 years after surgery. And depending if we still have any concern or not, at that point, we send them back to the radiologist or the endocrinologist to follow up with and get their ultrasounds done from there on. Versus if we still have any concern, we keep following them. And I have a couple of patients that we continue to see, 10 years down the road, is because studies have shown that when you get your imaging ultrasound at the same place, using the same equipment, with the same person interpreting them, you have less variability in the results. So one thing that I would ask you is, when the radiologist performs them, are they just still images that your endocrinologist or endocrine surgeon is looking at? Maybe it's worthwhile checking in with your endocrinologist or endocrine surgeons for them to perform an ultrasound if there is any concern for recurrent disease, to evaluate them, because then it's kind of a live 3D image that we can interpret. But in terms of the length of the procedure, it's usually 7 to 10 minutes, because we can have a good understanding of the anatomy in that area, especially if it's an experienced person performing it. What determines if you should biopsy central and lateral neck lymph nodes post thyroidectomy radioactive iodine? Is thyroglobulin is relatively stable? Would size alone bigger sway a surgeon to biopsy? So it all depends on, what's the pre-test probability. If you have a thyroglobulin level that's normal, the chance of having an abnormal lymph node harboring cancer is very minimal. So if the thyroglobulin level is undetected, I wouldn't really be chasing after lymph nodes and biopsying them, because it's highly unlikely, especially if the tumor was expressing thyroglobulin. But if we start to see a thyroglobulin level, it's slowly creeping up, I think it's worthwhile evaluating the neck. But again, as I mentioned, the American Thyroid Association doesn't recommend chasing lymph nodes that are less than 8 millimeters in the central compartment or 1 centimeter in the lateral compartment, because the benefits don't outweigh the risks in these patients, and they recommend continuing surveilling them with ultrasound. Now, if we're seeing that on ultrasound and they're growing, then we would biopsy and see if the biopsy is going to alter management in terms of going back in to clean the lymph nodes or not. For a young adult with papillary thyroid cancer, 10 years post-thyroidectomy, what are our current recommendations for annual ultrasounds? So if you've gotten to 10 years without any concern for recurrence, that's very reassuring. I don't think that you would need annual ultrasounds at that point, given as long as your previous ones have been negative so far. But I do think that you would still need thyroglobulin and thyroglobulin antibody testing every year. And if there's any abnormality in those, then proceed with an ultrasound. But that all depends on what your pathology is and what the discussions are with your endocrinologist or endocrine surgeon. Can an FNA biopsy miss the cancer in node checking for recurrence? Would a thyroglobulin washout guarantee an accurate positive or negative result for recurrence? Yes. So studies have shown that just looking at the cells under the microscope, you miss 20% of cancers. However, if you test for a thyroglobulin washout, it's almost 100%. But the caveat is you want somebody who is doing the biopsy, or you want to know who did the biopsy. Did they use ultrasound? Are they comfortable with using the ultrasound? And was their sample reliable, meaning that they were biopsying the lymph node, not the tissue around it when they got the sample. So as long as those things are present, having a TG washout that's negative, that's very reassuring.
Dr. Noureldine, I wanted to let you know we have about 10 minutes left.
Okay. Just let me know when it's almost time to end the session. I'll keep going with the questions if that's okay.
Sure.
So 16 years post-thyroidectomy, I have a palpable enlargement beneath the back left part of my chin. Ultrasound inconclusive as to whether this is a lymph node or not. Should I pursue any other kind of imaging? I think biopsy would be helpful to determining, the main concern here is this recurrence of disease, or is this a metastatic foci of cancer? And I would start with a biopsy to reconcile what that is, because that can give you a very good idea of if this lymph node is harboring any thyroid tissue, because if it is, then we know that it's cancer. Other imaging studies would be radioactive iodine scan, because if it has any thyroid cells, it would light up in that area as well. Are hypoechoic and hypoechoic nodules suspicious post-thyroidectomy in differentiated thyroid cancer? Not necessarily. It depends on other characteristics as well. Depends on if they're growing in size. But just looking at their echogenicity, we've seen hypoechoic and hyperechoic ones that are benign, but you have to look at the other characteristics of ultrasound. You described the recommendations for nodule biopsy. What are the recommendations for lymph node biopsy? So lymph node biopsy is mainly how they look on the ultrasound, their characteristics. I showed you the table of the buzzwords, if they're round, they have high vascularity, if they have a necrotic component, basically looking suspicious. And then the size characteristics as well, 8 millimeter above in the central compartment, 1 centimeter above in the lateral compartment. My doctor referred for me to travel an inconvenient distance to get my yearly ultrasound. My understanding for this is that I only have confidence with the ultrasound department and the technicians at this particular university hospital. Technique. So the question is about how how different people can reliably evaluate ultrasound for recurrence using ultrasound. Unfortunately, there's a large variability. A lot of places don't have a dedicated thyroid or endocrine ultrasonographer or radiologist interpreting those results. It can be just kind of a general person with general training of ultrasound. So I feel like if your physicians at this point are concerned that they want you to be followed up with a person who has specific training and interest in this field, then maybe it's worthwhile to follow up with them, although it's inconvenient. However, you can also ask them, at what point are you comfortable with me just following up with the local person as well. Should a patient be concerned when neck ultrasound completed in 15 minutes versus neck ultrasound takes 30 minutes? Ultrasound was done 2 different ultrasound technicians. I would say no. It all depends on the experience. Usually my ultrasound takes about 7 to 10 minutes, even for my mentors. And sometimes the technicians take up to 30 minutes. Sometimes when I just need to evaluate things closely, it does take me about 30 minutes. So it depends on each scenario, but I wouldn't discount the one that was done in about 15 minutes. How do ultrasound interpreters differentiate between thyroid cancer cells and scar tissue residue from a total thyroidectomy? So sometimes thyroid tissue grows back, and it doesn't have to be cancer. The way to differentiate it would be to biopsy it. Looking at the cells, it would tell you if it's cancer cells or not. Can the surgeon see abnormal lymph nodes while she is operating? Do they look in other than the central compartment? So in our practice, once the patient goes to sleep for surgery, we perform a comprehensive neck ultrasound. And the reason why we do that in our practice is, one, when you're asleep, we can press more with the ultrasound probe and be more comfortable evaluating all the compartments of the neck. But when we do the surgery, for example, just to remove the thyroid gland, we are only looking at the central compartment. between those big vessels that I had discussed with you guys. So we don't typically look in the lateral compartment during surgery because we don't want to violate those tissues and cause scar tissue and damage, but we do evaluate it with ultrasound. Is
We have
there,
about 5 minutes left.
all right, thank you. I'll just answer maybe 5 more and or we'll see. Is there ever a scenario where thyroglobulin wouldn't be a good marker for recurrence? Yes, if there are any antibodies, if there is still thyroid tissue behind, yeah, I just can think of those 2 scenarios. You showed charts showing increase in recurrence over time. I've also heard that chance of recurrence disease refers to after initial treatment with the highest recurrence within the first couple of years. Does your chance go? It doesn't go up. It's, as you said, it's higher within the first couple of years. That's why for the person who said that they've been disease-free for 10 years, I said that was reassuring. But we have seen that it still comes back even a couple of years after, and that's why there should be ongoing surveillance of some sort. Can ultrasound be dangerous if the one is left in one place too long? No, so ultrasound is used for on pregnant women and to look at babies in the uterus. It's completely benign. It's just ultrasound waves. It has no damage even if left for a long period of time in one place. I have total thyroidectomy for papillary 27 months ago with local regional lymph node removed, have 4 ultrasound all clean every 6 months. Should I continue ultrasound for 6 months? Thyroglobulin decreasing from 11.3 in October. I would refer to your endocrinologist or endocrine surgeon, whoever is managing you. 3.2 for a thyroglobulin level is not normal. I think the upper range, at least for our institutions, is less than 2.5. So I would continue every 6 months if that's what they recommend. I'm sorry for the remaining questions that we weren't able to get to them. I don't know if there's another way that I can get to them and answer them.
I do think that we still have about 3 minutes, so you might be able to get through another 1 or 2.
All right, let's see, where did I stop? Can someone have a low thyroglobulin but cancerous lymph nodes? Yes, if the tumor itself does not express thyroglobulin, and usually that's in poorly differentiated thyroid cancers, some Hürthle cell carcinomas, but the vast majority express thyroglobulin. And I don't think there's a study that looked at, do you really need ultrasound if the thyroglobulin is low, vice versa. So that's something that is up for studying as well. When is it necessary to do a 3D ultrasound versus regular ultrasound? I'm not familiar with 3D ultrasound. We usually do a regular ultrasound. There's some technology that came out that looks at the compressibility of the tissue to give us guidance if one is suspicious or not, but that's not the standard of care, at least, and that's not what the American Thyroid Association recommends. Can you speak to remnant tissue that is always left behind by surgeons to preserve clinical structures? Should remnant tissue be monitored? So the ATA guidelines that came out in 2015 recommended whenever a thyroidectomy is removed for cancer that it be a total thyroidectomy, meaning removal of all thyroid tissue. They moved away from subtotal thyroidectomies where tissue is left behind around the nerve or the parathyroid glands. Usually a high volume surgeon, an endocrine surgeon, is able to accomplish a total thyroidectomy without damaging those structures. However, if you do have a remnant tissue after a cancer case, unfortunately, because they left them around the nerve, then studies have shown that that's the likely area of recurrence. And because it's connected to the nerve, it can invade into the nerve. So that's why the ATA moved away from subtotal thyroidectomies and recommended total thyroidectomies.
Well, thank you. We've run up to 5
Okay.
o'clock. I'd like to thank you for this wonderful presentation. And you were right. You said I was going to learn a lot about ultrasound, and I absolutely did. So thank you very much for your time today.
No, thank you. Thank you for everybody. Have a good day.
Thanks.